afternoon. COVID-19 was the first pandemic of the digital age. From contact tracing apps leading to stay-at-home orders to vaccine prioritization and identification of vulnerable groups, data has been critical. It has informed and enabled evidence-based policy, public health and clinical decisions on how to effectively respond to various stages of the pandemic. So the pandemic has proven that data is one of the greatest assets, yet most countries have struggled to provide the required data, especially in the early stages, and fewer still have the capacity to analyze the data in meaningful ways. My name is Luisa Baldini. I'm a former BBC correspondent, and I'm delighted to be leading this conversation this afternoon on data-enabled responses to COVID-19. We're going to be discussing examples of successful national data infrastructures and responses with a view to identifying potentially transferable policy lessons for other nations. So without further ado, I would like to introduce to you our panel who are going to join me here on stage. Firstly, we have Professor Sir Aziz Sheikh, who is Director of the Usher Institute at the University of Edinburgh. Sir Aziz works for the Institute, whose vision is to catalyse the transformation of health in society by working with people, populations, and their data. Welcome, Sir Aziz. We're also joined by Dr. Ahmed El-Magharamid, Executive Director, Qatar Computing Research Institute, established by the Qatar Foundation. We have Dr. Youngmi Ji from Korea. She is CEO of the Institut Pasteur there. And lastly, but not least, we have Dr. Abdulatif Alkal, who is Chairman of the National Health Strategic Group on COVID-19 here in Qatar, and he has a background in infectious diseases. So just before I start off with questions up here on the podium, just to say to any of you here in the auditorium with us, please do think of some questions that you may want to put to our panel. You'll have an opportunity in a few minutes. Anybody watching on the live stream as well, please don't be shy. Please submit your questions using the app. You can enter them in the chat box. And actually, anyone here in the auditorium, if you'd prefer not to raise your hand and ask a question out loud, then you can use the QR code on the screen behind us. You can scan it from wherever you're sitting in the room, and you can type your question in instead, and I will get any questions on my iPad here. But while you're thinking of those questions, maybe you need some thought-provoking, so let's start here. Professor Sir Aziz, you've authored a report on the subject with Wish. What are the various data sources that you refer to in the report that should be ideally available at various stages of a pandemic?
So data are absolutely fundamental to responses to pandemics. I mean, I think we've all learnt that. The insights that we and colleagues from a number of countries have been able to provide, I think, have been absolutely transformative in terms of trying to get us to where we've got to. We're not out of the pandemic, but I think clearly it's a different situation that we find ourselves in. So as we think about this in the round, I mean, we need data around sort of the emergence of new infections, and particularly those with pandemic potential. Now, quite often these infections will be arising in animals, so they will, I mean, ideally the need for monitoring and then transmission from from animals to humans. And so many sort of institutions across the world are thinking about a One Health approach, thinking across sort of animals and humans, and that is really important. What we then need are data that can be used to answer basic questions of epidemiology. So, I mean, how quickly are infections spreading? Which populations are most vulnerable? What is the kind of growth time in infection rate? What's the incubation period? So really, I mean, data are needed really in all of those considerations. So really very basic questions around epidemiology. What else we highlight are the ability to risk stratify. So as you mentioned in your introduction, I mean, there are vulnerable populations, those who've been disproportionately affected. Yes, we're all vulnerable, but some individuals are sadly sort of most prone to the serious outcomes. So how can we identify those? And those I mean, will vary depending on sort of which infection we're talking about. And then, I mean, as therapeutics and vaccines become available, being able to look at uptake, assess vaccine and therapeutic effectiveness and safety, I mean, are all important considerations. What we've learned is around variants, and so data around sequencing and the emergence of variants are important. And I think maybe just finally, one of the things that we've had to try and balance in all of this as we try and sort of decide what social restrictions to pose as we move into lockdowns is the pressure on our health systems. So to what extent are health systems disrupted? What are the risks that they may well be overwhelmed? And that's a balancing act. And again, we need data on health system functioning, capability, pressures going forward. So I mean, what we need are a whole array of data to really inform responses.
Thank you, Sir Aziz. And Dr. Ahmed, what about the role of artificial intelligence and making sense of big data when it comes to preparing and responding for future pandemics?
Yes, so I read the report that was produced by the group at WISH, and it's very thorough. So I want to take so I'm a computer scientist, and actually I work in data science and databases, but I want to just alert that AI, that this is not an AI problem, that this is not a data science problem, that this is actually a healthcare problem, and it's a very complicated problem. It's a system of systems problem. It was very clear during the pandemic and sort of even before it was announced to be a pandemic, that this is a public health, there were issues in which AI could contribute. There were some aspects in which AI could contribute, but it's not everything. So, in fact, just to give you, I mean, I felt as a data scientist that in the early days it was almost like the Wild West. And Dr. Abdul Latif probably and the healthcare providers were scratching their head, because you find all types of announcements and all types of results that were built either on too small of a data set to have really a meaningful conclusion, or they were sort of based on many different data sets that were not properly deduplicated or cleaned. So there were conclusions that were being made on unclean data and so on and so forth. So we have terms for this in AI. It's like Frankenstein data sets. They're just too small of data sets that when you integrate them, and they talk about data integration quite a bit in the report, when you put them together, if you're not careful, you end up accumulating the error, because it's these data sets that cover the same population, and it keeps getting amplified. And when your algorithm tries to come up with these models in which these results are built, you have something that's over magnified. So we saw a lot of nonsensical algorithms and so on. So one has to be very careful. And anyway, as we go in the discussion, I will give you specific examples.
Yeah, thank you. But thank you for that initial thought. And so, Dr. Youngmi Ji, overall Korea's response to the COVID-19 pandemic has been considered extremely successful. How much of that do you consider to be due to data-driven leadership and agility?
Thank you. First of all, I want to thank the Qatar Foundation and WISH organizers for inviting me to this session. And also, I really want to appreciate Professor Sheikh for providing such an excellent document as a background of this session. I'm not a data scientist. I'm a public health doctor with virology background. I think whether Korea really used those data very well for the policy decision and leadership probably can be different. But I think that Korea has very extensive health data infrastructure and sources, and government really tried very hard to use such infrastructure to some extent to be used for the policy decisions. And also, government operated many advisory committees which can really advise government for policy decisions such as social distancing and public health measures and introduction of vaccines and therapeutics. So those advice from the committee, of course, based on the national and global data, provided the background for the policy decisions. But I think there are still some rooms for the improvement in terms of depth and the speed, and also the capacity to really analyze those data need to be strengthened further. That's my initial thought.
So more speed, more work on speed and analysis. Thank you. We will be coming back to some of these thoughts, but let's hear now from Dr. Abdulatif Al-Khal. Qatar has done a great job in upscaling its data capabilities to inform the pandemic response. Can you tell us more about what's being done and what's helped drive policy decisions during the pandemic?
Sure, thank you. I also would like to take this opportunity to thank the organizers for inviting me to join this distinguished panel. And I would like to thank Dr. Aziz and the team that worked on the report, Data-Enabled Decisions. I found the report very useful. So I think at this point we have a huge amount of data, knowledge, and experience and tools that we developed over the past 2.5 years in our response as a global community to the pandemic. And I think those knowledge, information, and tools can stop the next pandemic at its root if it's used properly by the global community. At the start of the COVID pandemic, there was severe lack of data to enable data in guided decision making. And it was like walking in the dark, really, when it came to public health measures, treatment options, or policy making. We had no idea how the virus epidemiology will evolve, and this resulted in different countries responding very differently from one another in their national response to the pandemic. The pandemic has made clear the importance of access to multidimensional high granularity data in real time to inform evidence-based policy making, public health, and healthcare system responses. Policy and decision making in response to pandemics should be driven by science and data and not by bias or political agendas. Most countries had struggled to provide the required data, and fewer countries had the capacity to analyze these data in a meaningful way. However, a few countries managed to leverage their existing national health data infrastructures that were in place to guide their own national response to the pandemic. Qatar was one of those countries, fortunately. I would like to share with you 3 key areas where we use data in practice, and we found it very effective. First is the centralized data warehouse. Since 2011, Hamad Medical Corporation, which is the tertiary care system in the country, public system, and the Primary Healthcare Corporation, which is also a public care provider, have maintained a single electronic health record. It's called Cerner. across all 13 hospitals and 27 primary healthcare facilities. We also quickly expanded Cerner coverage to include all the newly opened facilities, whether isolation facilities or quarantine facilities, in addition to the airport and the border. To meet the big demand that was placed on us by the national response to the pandemic, our health data infrastructure was repurposed, enhanced, linked, integrated, and interfaced to be able to generate meaningful real-time data to keep up with the demand. We created what's called the COVID Data Mart, which provides a single, reliable, authenticated source of data published on demand from a central warehouse, as opposed to multiple sources producing data. Our data warehouse compiled centralized national database on COVID-19 linked to unique patient identifiers, which is the category identification number, QID. And this proved to be very effective. This data is reviewed and evaluated by a national scientific committee that's under the Ministry of Health, and it's led by Dr. Roberto, who's here in the audience, and also reviewed by the National Health Strategic Command Group. Decisions were made based on this data. The other example or area where we found this utilization of this data is very useful is with what's called Ihtiraz, the official COVID-19 smartphone application used by the country. The app has been a cornerstone in our efforts to ensuring compliance of the public with the required testing, isolation, or quarantine, and has helped us to reduce the spread of the virus in the community. It's mandatory for all adults in Qatar, and it's provided a live status for each person's current COVID health and vaccination status. Underpinning the Ihtiraz app is an automated data engine called Ihtiraz Data Engine that continuously processes and updates the status of every registered user on an hourly basis, or even less frequent, or more frequent than that. Ihtiraz, by the way, in English means being careful or being prepared. The third area where we used data is projection models, trying to predict the behavior of the pandemic during the different waves that we went through, particularly severe waves like the initial wave and the Delta wave. A group led by Dr. Laith, who is also, I think, in the audience, did a great job in coming up with models that predicted how many cases to expect, cases of infection, how many of those will end up being admitted to the hospital, and how many of those will end up in the intensive care unit. And those models proved to be very reliable and highly accurate. And in anticipation, weeks before the peak, we opened more beds, more acute beds, more ICU beds. We redeployed healthcare workers to those beds. And actually, this helped us to reduce the mortality significantly. And that's why I think one of the reasons why we are one of the countries with the lowest mortality rates in the world.
Thank you, Dr. Al-Khal, for that overview of the way data was really used here. You've heard from each of the panelists, so please do ask any questions if you'd like to raise your hands, and I'll be checking if any come through on the app as well. In the meantime, I just wanted to ask you, thank you, we'll come back to you in 1 second, but thank you for letting us know you want to ask that question. Everything you've said really makes me think about training, because if people aren't trained in the right way, then none of this use of data is going to be effective. Dr. Youngmi Ji, you talked about improvements needing to be made when it comes to speed and analysis and Professor Seraziz, you talked around the 4 or 5 different categories of data that are really necessary. But without the training, then that data is not going to be of value. We were talking this morning to Professor Mahmoud Adil, who Seraziz you'll know from Scotland, because he used to be the National Medical Director of Public Health Scotland. And when it comes to data, he said it's about volume, velocity, variety, but it doesn't have the value if it's not dealt with in the right way. What would you say about training then?
Yeah, no, I mean, I think training is incredibly important. So when we're running individual analyses in a COVID space or in anything else when working with routine data, the way I kind of try and conceptualize this is that I need people who understand the domain. So if it's looking at sort of vaccine safety and cardiological endpoints, I would need cardiologists in the team. We're talking about sort of then people who've got understanding of the strengths and limitations of individual data sets. And as we were discussing earlier, quite often we are linking up data sets. So we need people who've got sort of appropriate database expertise. And then we need sort of the whole army of data scientists. So these are people who are going to data wrangle, data process, curate, data link, data security considerations. Then, of course, the analysis considerations, but then we're using the data and we want people who can help with visualize, interpretation, and then making the case on the back of this. I think there's also the need for data literacy at the other end, because, I mean, I think, for example, in Qatar, and we were just hearing about, I mean, Qatar has done exceptionally well. I mean, I think it's been a regional, global leader in this respect. But what you need are leadership who are kind of data trained and data literate, who understand, I mean, the strengths, limitations, that this is one source of information. They may need to sort of validate, triangulate, be drawing on other data sources, that you can have those open, mature discussions. So there's kind of training not only sort of in the health data science space, but also with the clinicians and with the health leadership as well. And I think we're really at the beginning of this journey. What we're seeing globally is that, I mean, every health system in the world is moving to digitized infrastructures. The volumes of data that we now have available, whether it's in Qatar or in Scotland or elsewhere, I mean, just absolutely enormous kind of volumes of data being generated at pace. So the opportunity is going to be phenomenal going forward, but we need the kind of workforce, the woman and man force who are going to sort of work these data for public benefit. And that training journey, I think we're just at the beginning of.
Yeah, thank you. Would you like to add to that, Dr. Ahmed?
No, yes, I was just going to say that one aspect that proved to be very important is collaboration. The fact that one of the biggest things that at the onset of COVID in Qatar, everybody pulled together, and Dr. Abdul Latif pointed to Dr. Laith, who's an academic, but who is a professor at Cornell, and who stepped in, and it was very, very helpful. We are a group of computer scientists at the Qatar Institute, Qatar Computing Research Institute, and we were there from first week, trying to help to see where we can lend a hand. I'll just give you a couple of examples. At the very, very early stages before Ihtiraz, and Ihtiraz has been tremendous. If you're, I mean, it's just something that should be emulated. But that Ihtiraz took a few months to build, almost 6 months. And at the offset, in conjunction with the National Command Center, we developed a contact tracing system, not an application, it was a back-end system that was used in the trenches to do contact tracing, to answer problems and so on. And that system withheld until Ihtiraz was up and running. For example, we've developed a system to study traffic patterns on top of Google Maps, where to answer some simple questions. Where is the traffic? You know, at that point there was a lockdown, so we wanted to know where the traffic is and so on. And there's some very interesting, unexpected questions. Like, so for example, at some point people were saying that traffic around gas stations was very light. But in fact, when we did the analysis, the traffic around gas stations was at night, and it was much more busier at night. So there was a lot of interesting work done. And just last example is we developed this self-assessment tool that was used. We developed in 11 languages. Local languages are spoken by laborers and residents in Qatar. And it was used over 1.3 million times. So this is an example where us as computer scientists were able to do whatever little we could do to help, and academics from Weill Cornell and so many other places were there, and we were at weekly meetings that Dr. Abdul Latif had mentioned, scientific committees. So there were all kinds of things that were happening. So I want to emphasize the importance of collaboration among the different segments in society, and the importance of curated data. The examples that I was given early on, you know, I mean, obviously making something about the use of AI or the overuse of AI on smaller data sets, but these examples that Dr. Abdul Latif and Sarah Sheikh were mentioning were on curated data. This is data that was vetted and cleaned and so on and so forth. So I just wanted to make the point about the importance of collaboration.
Thank you very much. And Sarah Aziz, I saw you nodding very vigorously there. Before we, just briefly, because we do want to take audience questions, what did you want to expand on?
Yeah, so I mean, just kind of briefly to kind of, I mean, expand and echo. So we previously at the last previous WISH Summit had a panel on data science and AI in healthcare. And at the time, a lot of this was conceptual, but I think what we've now got is a kind of a real world worked example that matters to all of us. And I think the collaboration was kind of pretty unique because there was a pull. So, I mean, governments, health system leaders, all of us wanted answers. And what we then also had was, I mean, the academic and clinical and community pulled together, I mean, I think in ways that I've never seen before, working across disciplinary boundaries, institutional boundaries, quite often national boundaries as well for a common goal. And I think going forward, I mean, it's about how can we sort of capture that and take that forward into peacetime, and then also, I mean, try and sort of ensure that we make progress on so many of the other big challenges that we've got, whether it's cancer or cardiovascular disease, because we've got a worked example there. Now, it's no longer a kind of an abstract exercise.
Thank you very much. Right, let's take a question from the audience. You had a question. Could we get a mic, please? Thank you. Please let us know if you'd like to direct your question to anyone in particular.
Sheikh, Sir Sheikh, to start with, and maybe Dr. Ahmed also. Many countries had access to data management capabilities that are comparable, but their responses varied wildly, from China's zero tolerance to Sweden's model. And that could be related to not so much just the data, but more to risk management and risk tolerance. What it seems to be the link between the response and the data, if you like, the risk philosophy and so on. What do you think about, I mean, how important is this? Can we like discuss this aspect a little bit more? Because it doesn't seem to me to be automatic that you have the data, so the response would be the same if the same data was available. What do you think about that?
I mean, it's just what we were talking about. I believe that one advantage that we had here is the distance between the problem and the solution were close. Let me explain to you what I mean. That didn't make sense the way I said it. So the people who were responsible for delivering the response, people like Dr. Abdul Latif and others in the ministry, and the people who could help, the distance was very close. In many countries, you can't collaborate with so many different stakeholders very quickly. In this country, we do, because it's a small country. We know each other, and of course the fact that the healthcare system was resilient. So there are a lot of it was just impressive to me how data that was collected and people were responding to it and making decisions on it, and things were happening in a very short cycle. And again, I just want to emphasize that this is not a technical problem. This is not a technology problem. This is a healthcare problem. And answering it, we can't claim that AI or data science or data, big data or whatever solved the problem. It is a healthcare problem. And it's a system problem. It's a complicated system problem. Logistics, bringing vaccines, and so on and so forth, and financial, and so on and so forth. It's a very, very complex problem.
Yeah, no, I mean, I can concur completely, really. So, I mean, I think what we're arguing in the report is that, I mean, data provide opportunities to kind of think through your responses. So we talk about data-enabled or data-informed responses. Now, I mean, the approach any particular government will take will depend on all sorts of other considerations. So is this sort of, I mean, a top-down or a bottom-up society? What's your kind of philosophical position? What are you prioritizing? Are you prioritizing health over economics, or vice versa? So if your philosophical position is, I mean, around a herd immunity model, as for example in Sweden, or it's a kind of a zero COVID strategy, as for example is still being pursued in China, then, I mean, data can inform, and help you evaluate, how that is going. But ultimately, these are political decisions that have to be taken. That said, I think data were absolutely fundamental. So, for example, we know that, trials reported and trials were showing that vaccines were effective, but quite often we know there's a gulf between what happens in trials and real-world populations. So data enable that kind of assessment. We know about safety signals, so the trials were very small. Some of the safety signals that we're concerned about are very rare events. So you can only begin to study these as the vaccines are administered to hundreds of thousands or millions of people. So it's been important in that respect. Vaccine waning, the trials weren't able to study. It's the real world data that have informed those considerations. Whether vaccines are working in the context of new variants, for example, the trials will take months, if not years, to report. So I think this has been really important in all sorts of ways, but it's not a substitute for political decision making. That's up to politicians, really. We can inform, we can guide, we can sort of get into dialogue, but ultimately a lot of these things are political decisions, I think.
Political decisions, right? Dr. Youngmi Ji, would you agree with that? Is there anything you've just heard that resonates for you at the Institute or in Korea?
Well, the early success of the COVID control in Korea for the COVID was based on our experience after MERS. So after MERS, we have changed the structure for the control. For example, we established the Emergency Operations Center within Korea CDC. Second, we also established laboratory detection and analysis center, which played crucial role in establishing the national detection, COVID-19 detection system very quickly. Even it was early February 2020, we already established the national detection laboratory system with the emergency authorization of the PCR kits. And then the last one was risk communication team. So that was established after MERS. So that allowed us to very quickly respond to COVID-19, even before WHO declared public health emergency. So at the beginning, we really reacted very quickly. So we so-called had this 3T strategy: testing, and the tracing and treatment very quickly. And then another thing was actually transparency. So government tried to provide the briefing of all those situations, all those developments twice a day. So it was not only once a day, twice a day until like 1 year. So it really provided big trust for the government. Whatever government does, people really believed in what government was doing. So we thought that we were probably the champion of this COVID control, but later when the Omicron appeared in South Korea, then it was really huge case. Then the same strategy cannot be applied. So so our population is of 51 million. So maybe much bigger than Qatar, but I think we still can learn from Qatar what we can do better. And as I mentioned, in terms of data analysis capacity, although we really have a lot of data for health, a lot of health data, we still need to learn how to properly analyze those data to be used for the policy decisions. So I do hope this the venue of the WISH really can bring the leadership in this area for all of us to work together.
Thank you very much, Doctor. Are there any more questions here in the auditorium? Do we? Yep, we have one here at the front and then one at the middle to back. Okay.
Thank you so much. So, I mean, one of the great lessons out of Qatar response to COVID is, I mean, this is my personal lesson, is leadership. So it is the mindset. If you have leader, they do accept evidence, and this is the right way we need to go. And also, as mentioned by the professor, is like the leader, the mindset, accept the academia to be part of the whole decision making. So the willingness of like the connectivity, COVID is affecting everyone in the country, and also the social responsibility of the academia. They have something to do for the community, and so the whole science, the whole the knowledge hub for science, they gather, and the beauty of like the connectivity, making the system itself, and the political leadership who accept evidence, because there's a lot of countries that are better than Qatar. They have sophisticated kind of institute. Even they are the one who invented the modeling itself. But their response is very bad because of the leadership. So my question right now, it's how to communicate the evidence. Because, I mean, there's a lot of country, they have, like us, they have a lot of institutions, and they have the evidence, but the political part, they don't follow. In Qatar, we don't have this. And this is one of the criteria for success in this country. I guess Prof. Aziz, he can answer this.
Thank you.
Yes, I mean, I think one of the things that many countries in the world are doing at the moment, including my own country of Scotland, is we're constructing pandemic preparedness plans going forward. I mean, as was mentioned earlier, I mean, countries that had experiences from SARS and MERS, I mean, have done incredibly well because they were able to sort of repurpose some of those plans. I mean, we had plans predicated on influenza. I mean, God knows where they were, but they hadn't been rehearsed, etc. So going forward, we are sort of, I mean, trying to get ourselves on a better footing. And as we do that, I mean, we are looking to countries that have done extraordinarily well under very difficult circumstances. And Qatar is one of those. I mean, hence, I'm absolutely delighted to be here, to be learning, really. I mean, because this country has not come from nowhere. but it has leapfrogged so much of the rest of the world. And I think there are important lessons to be had. We discussed this earlier. Part of the secret sauce here has been not only the leadership and the kind of close liaison between that leadership and independent scientific input, but the fact that you have a single implementation of an electronic health record across the entire country.
Yes.
There's very few places in the world that have that. Many of us are kind of grappling with legacy systems and all of that involves. So you have the ability to leapfrog, show the world what the future is about. Absolutely. And I think other vehicles to try and do this is, of course, the World Health Organization. So they are represented. They were on the panel on health system resilience yesterday. We have EMRO leadership here, for example. So I think, the fact that also what's important is that, as we were running these analyses, it was primarily for government agencies, public health agencies, for the response. But what we have subsequently done, and you guys have kind of exemplified this, is you've published your work in the peer-reviewed literature. Now, that's been always a secondary consideration, but this is the record that remains. It's the record of legacy. And so, the world can look at this, and it's published in the foremost journals in the world. Some of the leadership here is in the room. So I think you've played a fantastic card here that we can learn from. It's not perfect, none of us are, but I think it's been a phenomenal response in my experience, really, I think.
Thank you so much. We'll move on to the next question now, as we've just got a few minutes left. I saw a hand up there earlier, yes? Who's your question directed to? If we could keep it to a question, that would be fantastic. I know everybody's got lots of thoughts.
No, I wish I could do that, but I think it's also important to provide some information.
If we
or
could
some
just
context,
keep it a little brief, because we've got less than 4 minutes left. Thank you.
My name is Kwesi Boahene. I'm from Farm Access. We work in Africa, and we participated in the report, which is being launched here. And it's an important topic. So in our own way as an organization, we leveraged technology and data to support some of the countries in responding to COVID, where, as you know, about 50% of the healthcare in Africa is provided by the private sector. And COVID struck, and people were not going to the hospital. And some of the hospitals, they have challenges. Some even were, at the point of going bankrupt. So leveraging technology, we're able to provide them with financing, because through the technology platform that we had, we could have insights into their turnover. So they didn't need to have collateral to get financing from us, and it saved a lot of facilities. And we also did other initiatives on supporting them to improve upon their delivery systems and also control infection, because most of the healthcare providers were also afraid at the risk of getting infection. My question, I have two questions, and please choose which of them is easier to answer. So the first one, I'm trying to link what I've learned, over the past 2 days to the conversation here. When epidemic strikes, the important thing is to be able to identify the risk populations and provide better response. And I was in the conversation yesterday where they were talking about precision medicine, trying to understand the groups and etc. And I'm wondering, is precision medicine the way forward for managing epidemics? And I think this question goes to the professor second from my left, because I thought you were in the group there. And the second question is, we all believe that data is important, but what can you do in responding to epidemic when you don't have data?
Good question.
So very quickly, the question about personalized medicine, obviously there are many, many people here that could answer it better, but I wanted to point, in Qatar, early on, there was a decision to develop a genomics program. So we have this Qatar genomics program in which the ambition is to sequence the whole population and to have full sequences, whole genomic sequences on the whole population, and to use it for research and to improve health. As you know, there is the Qatar National Vision 2030, and health is a major pillar in this. So So we are unique in the sense that, again, I keep coming back to the fact is that it's a smaller country, therefore a vision like that could be implemented in a more reasonable way. So I invite you to familiarize yourself with the Qatar Genome Program and with the personalized medicine in Qatar.
Thank you very much. And the second part of that question, what happens if there's no data?
You pray.
And at that point, I think we should probably end, but I just really want to put to you the question that has come through on the app. How can we ensure ethics and data privacy considerations are in place with AI and data-driven apps? I think that's one for you. Ethics and data privacy.
Yeah, so so this is the other side of data. So you collect data and you can have, what you need is a proper governance structure. It's very, very important to have a proper governance structure and the responsibility. And as much as we say, really there is got to be an authority, and it's typically with government to have policies in order to enforce privacy. And we saw what happened with social media. We saw what happens with public data, that if it's not properly governed and properly monitored and so on. Now there's some improvements where you could set privacy settings and so on and so forth. So in terms of the question about ethics, it's a very complicated question because it's part of transparency and what transparent use of data means. So ethics would be one of these things, data governance. And in Qatar, we are, again, I'm saying that we are fortunate that we were one of the early countries that developed a national committee, a national strategy for artificial intelligence. And within this, personalized medicine and healthcare were some of the important pillars. And in fact, now we have a national committee that is in charge of figuring out ways to promote and to implement this strategy. This is under the Ministry of Communication and Technology. And so there are many, many activities that we can do here that perhaps are more difficult in a more sort of disparate, more heterogeneous system. So you mentioned, for example, the fact that there are a lot of capabilities. Say, for example, in the United States, it's very difficult to implement things very quickly because the provisioning and management and responsibility for healthcare is very diffused. It's not only at the federal level, it's not even at the state level, it's at the county level or at the community level. So we are, in a sense, our circumstances helped us in some of these aspects.
I'm afraid we will have to end it there, but thank you very much indeed. Thank you to our audience for your questions. For those of you watching on the live stream, I'd like to thank our panelists, Professor Sir Aziz Sheikh, Dr. Ahmed Al-Magharmid, Dr. Youngli Ji, and Dr. Abdulatif Al-Kal. Shukran.